Today we have Dr. Scott Sands. He's a medical doctor with a specialty in ophthalmology. His career has spanned over 50 years, serving both in the military and civilian roles, and he is currently the staff ophthalmologist at Golden Eye Clinic in Ennis, Texas. So today he's going to talk on the complex eye, intelligent design, and natural selection. Dr. Sands?
All right. Thank you, David. And I want to just say it's great to be here this morning. Thank you for the opportunity of sharing with you guys some of the knowledge that I have accumulated over a few years in comprehensive ophthalmology, of actually over 40 years. A little bit about my background. Before we do that, though, I want to thank David and Bob for inviting me. Thanks so much for that. This is a little different venue than I'm used to. I feel my comfort zone is one-on-one with patients in the office, so this is just a little bit different, but we'll do our best to explain some things and talk about the complexities of the eye. Mike, I don't see where Mike is now, but he did a great job. Oh, there you are over there. Thank you so much for your talk. And I guess one of my questions I didn't get to ask was, so why did they choose, natural rubber of, what was it, 30% I saw up there? I assume there's some physical characteristics reason why for that, but we'll talk later so I don't get behind. So talking about well, before we do that, just a little bit of background. I came to know the Lord when I was 12, 13 years of age at a Billy Graham crusade in Los Angeles. Tended to walk away from the Lord during college, but then got married and to a lovely wife, Mona, of now 56 years. We've been together, and hopefully many more. And we have 12 grandchildren, and Amy and Jeff are here, my daughter, and son-in-law are here, and of course they have 4 kids, and then I have 8 other grandchildren. So I've been very blessed and thankful to the Lord for leading me and keeping me out of too much trouble as I have progressed in my profession and my role as a dad and husband. Okay, so without any further ado, let's just kind of jump into this talk. Hopefully I'll be able to convince you that the complexities that you see, Mike was talking about the microscopic or the micro world in terms of biochemistry. And by the way, I made a B in biochemistry. Barely. I was real close to the C, so I could relate to what you said. But at any rate, so what we want to do is see if the complexity tells us whether there really is an intelligent designer or not, and I'll let you be the judge of that, but let's go through it. A few years ago, when I was on the faculty at Texas Tech teaching, one of our graduates who went on to be a clinical ophthalmologist, I read this in her bio, and she's practicing in New England, but she said, I chose ophthalmology because I'm fascinated by the complexity of the eye and in all of the massive impact this small organ has on our life's journey. So I thought that was pretty insightful. I wanted to share it with you a little bit. When I decided to go into ophthalmology, mine wasn't quite so altruistic, but anyway, it has changed since then. All right, so this concept of irreducible complexity, you may have heard that. You should have gotten an article that it was passed out, and it basically talks about the tear film and irreducible complexity. And I think you'll find that read is an easy read, but it's really going to illuminate things. I'll go through some of it with you, but I think you'll really enjoy it because we think about tears and we just think about water, but there's a whole lot more to it in terms of the health of the cornea and the surface of the eye. So at any rate, reading this system composed of multiple interacting parts where the removal of any one part would cause the system to cease functioning. So there's a lot of different examples, and I think I'll hopefully show you that the eye is one of those examples of irreducible complexity. One of the more famous ones is the mousetrap. You remove any one of the items of the mousetrap, and you don't have a mousetrap that functions anymore. So just our pointer isn't working, and I was hoping to have a pointer because there's a lot of detail here, but this is just an overview, the external eye, and then a cross section of the eye, and these are illustrations. So, but the basic point I want to get over to you is a little bit about the external eye and understanding. A lot of people don't understand, the tears are made up here, they flow across the eye. When you blink, they're pushed nasally, and there's two little puncta, superior and inferior puncta, where the tears go out, and they go through canals. This is under the skin, you don't see that, and it drains into the nasolacrimal sac, and that nasolacrimal sac then drains the tears into the nose. So if you're crying, you probably notice that you have to blow your nose more, and that's the reason why. And where that comes out in the nose is very close to the opening of the maxillary sinus. They're very close. So, at any rate, and then a cross section of the eye, just generally to get oriented a little bit. You've got your cornea here in the front, and then you have the anterior chamber, then the natural lens where people get cataracts. There's the ciliary body, the zonules, that's important to understand. And then you've got the sclera, then you have the optic nerve that goes into the back of the eye, the posterior segment, and spreads out. And basically you have your brain is in your eye, better known as the retina. So we'll talk a little bit more as we get farther down the road. This slide goes along with the handout that you have in terms of the complexities of the tear film. What you probably don't know is the cornea, the front surface of the eye, the clear window of the eye, is actually about 3 millimeters. Is that what's going on? Thank you, Dal. Appreciate it. So it's about a 3 millimeter thickness. And most people just think maybe it's smaller than that. But then you have 3 layers that are involved in the tear film. It isn't just the watery layer in the middle that's coming from the lacrimal gland up here, but there's a mucus layer that is the first layer on the surface of the cornea, which you see right there, and then the watery layer, and then the oil layer. And one of the more common causes of dry eye is called evaporative dry eye. And you can produce a lot of tears, the basal tear production, have good mucus layer, but if you don't have the oil layer to protect from evaporation, then your tear film beads up very quickly, and then you get dry spots in between, but yet you still have plenty of tears. That's very common as we have birthdays under our pocket. The older we get, these meibomian glands often get stopped up and don't secrete enough oil to prevent the evaporative process. The other thing that probably is conceptually something that you haven't heard of or maybe don't have a good handle on is the anterior segment or the anterior chamber, which is this space here. There's your cornea with the thickness that we're talking about. That's the iris, the pupil, and then there's this little thing called ciliary body. The ciliary body produces the aqueous fluid. And the aqueous fluid is really important in terms of keeping the eye turgor the way it should be, because if the pressure gets too low, the eye doesn't work well. In fact, it can lead to what we call hypotony, which is no pressure in the eye and total loss of vision. Or if the pressure gets too high in the eye, there's usually a balance there where it doesn't happen, but if it gets too high because the resistance of the outflow is going up or the production is going up, then you can get glaucoma, which is damage to your optic nerve and eventually lead to blindness. So the fluid flows around here. There's a little canal called Schlimm's Canal, and the fluid goes out Schlimm's Canal and goes through into the venous system and gets recirculated. Interesting concept and a great design because it works most all the time. And then just to give you a feel for in the office, most of you have been to an eye doctor and he's going to put you on the other side of this little gizmo here, and that's called a slit lamp. basically a slit lamp is a microscope with a slit beam. And that slit beam you can see here, right there, shows the depth of the cornea. And you can go to higher mag if you want, or lower magnification if you want. So it really illuminates a world that, for instance, if you go to the emergency room and they don't have a slit lamp, then the doctor there really can't see what he needs to see in general. So oftentimes they'll have people have a red eye and they'll diagnose the pink eye, but in fact there's really a uveitis or an iritis going on because they didn't have a slit lamp. They couldn't see the inflammation actually in the anterior chamber. All right, so let's go into the orbit. Some of you probably don't know that there's 6 extraocular muscles that control motility of the eye. There's 2 vertical muscles, 2 horizontal muscles, and 2 oblique muscles, the superior oblique and the inferior oblique. I don't want to bore you with all that, but the thing that, from a standpoint of complexity, and you engineers will appreciate this more, but right up here, that's the superior oblique muscle coming up, but it goes through that little pulley. And that pulley has to be in the right place, and the muscle goes through it, and the tendon comes down here. And that superior oblique muscle allows the eye to have infraduction or go down, and some excyclotorsion or some rotational movement this way. And the other inferior oblique will do just the opposite. So a little more complex than you might think. And of course, you don't see the muscles because the conjunctiva is covering up the muscles. Okay. And this is real basic. It's more complex than that, but I didn't want to get in too much detail. But I guess the point is that the blood supply to the eye comes in the major artery there is the ophthalmic artery, but that's a branch of your internal carotid artery. Some of you may have heard that. You have the common carotid artery, and then it branches off into the external carotid, the internal carotid, and then a branch of that is the ophthalmic artery, and then which also then branches and goes into the center of the optic nerve, and that's called the central retinal artery. And for those of you that are real detailed like Bob, this is the flow chart if you really want to go through a flow chart of the circulation to the eye from the aorta all the way down. And then if you look at the central retinal artery, that covers the inner retina. And then the other 2, the ciliary body and the iris. And then this other branch over here covers the choroid, which is a vascular layer on the outside of the retina, between the retina and the sclera. And when we get through with things, we'll have time, hopefully, to discuss things. And if you have any clinical questions, I'll be glad to try to answer those as best I can. So this is an orbit where you can see in no eyes there. But the point that I want to make, and in terms of complexity, it's called the annulus of Zinn. That's the red area there. Those are the insertion sites of the extraocular muscles. Now, there's some other things, but basically that. So those muscles don't work. If that insertion isn't in the right place back there, then the muscles don't have the right angles. It can lead to strabismus issues, double vision issues if it's acquired, or there's trauma or something like that. And then the optic nerve comes through a fissure in the back of the orbit, and then you have this longer fissure over here that has multiple blood vessels, multiple nerves, and veins going through it to supply the eye. So a little bit of complexity. And then you get to the retina, and this can get really challenging even for an ophthalmologist to learn all the different layers of the retina. But in general, where your optic nerve comes in to the back of the eye is actually your blind spot. So there's no visual capability or photoreceptors on the optic disc. I'll show this to you in just a minute. And the macula and fovea are located adjacent to that. What this is a very simplistic, blown up picture of the retina. Everybody's heard of the cones and the rods. The rods provide vision for nighttime type vision, dim light vision, and the cones are your cells the cells that are used to discriminate and have a really good sensitivity for daylight vision, for reading vision, discriminating, and things like that. So if you really want to talk about complexity, there is 10 layers to the retina. And so we took one that was real simple and got one that's a little bit more detailed, but there is actually 10 layers, definable layers, to the retina. And then to make this clinical, some of you, because of age, I know, have had this OCT test, an ocular coherent tomography test. Comprehensive ophthalmologist, optometrist, retina specialist will do this test pretty routinely. So what we just showed you in graphic or illustration form about the retina, that's it right there, but in real time. And here's the blood vessel layer, the choroid down here. There's a basement membrane, Brooks membrane, and then you get up into the different layers of the neurosensory retina. And you might wonder, well, why is it curved like that? Well, that's the way God made it, but that's normal. It's supposed to be curved, and when we get into pathological situations, the curve goes away. So I won't get into that detail at this point. So that's why that test is done. It's not something we had when I first started practicing ophthalmology, but it started, I think we started seeing that in the late 80s, early 90s, and now it's much more sophisticated, and you can get a test and that tomographic cross-section done in a matter of seconds now. Okay, so what does the ophthalmologist see when he looks in your eye? That is a photograph of what he's going to see in the posterior segment. There's your optic nerve over there where the arrows are. And then you can see coming out of that optic nerve is the central retinal artery. And there's arteries and veins. Technically, there are arterioles and venules. That supplies the inner part of the retina. And then right in the center, inside the green is what we call the macula. And you've heard of macular degeneration. And then inside the black is the fovea, which is the more centralized area within the macula that has the ability to, if it's normal and everything's okay, to see 20/20, or even better if you're Ted Williams or somebody like that. So, but that's what we see when we look inside, whether it's just using an indirect ophthalmoscope to look inside, or we're doing a photograph or what have you. I'd love to get more clinical, but I better get through the talk here. And for the fun of it a little bit, this is a fluorescein angiogram. I imagine there's one or two of you that had a fluorescein angiogram, most likely, if you've had any circulatory problems in the back. But it's not used as much as it used to be because the OCT test tells you a lot, takes the place of doing the fluorescein. But you inject some dye in a vein, it'll circulate through the eye. And it gives you the opportunity to really look at the detail of the circulation, especially in the macula. If you're a diabetic and you have had it for a long time, it's not unusual to see some capillary dropout in the macula, which decreases the vision. There's other things called branch retinal vein occlusions and things, central retinal artery occlusions. These would be clinical reasons to do that particular test, to look at the vasculature in detail to try to determine what caused the loss of vision. So, I've got more than this, but basically, when we're talking about complexity and intelligent design, to me, it's very obvious. There's some scripture there that kind of documents that, and in terms of different thoughts, you know, if you think of Genesis more of an allegorical sort of thing, then you may believe that the way the Lord created us was through a Darwinian evolutionary sort of pathway, or if you believe in a literal translation of Genesis, then you're going to be leaning toward just intelligent design and the God of Abraham, Isaac, and Jacob. So, what I'm thinking about now is I want to see if anybody has any questions, and then I do have, if anybody, I have some pathology slides of different problems. Brent probably be interested in that, but if you guys are interested in seeing that, I'll stay. David, how are we doing in time? We're good? Okay. Well, what I do is this. I'll just go ahead and show you these slides. And yes, ma'am.
So I know several people that are getting shots in their eyes.
Mm-hmm.
One I think is for glaucoma. The other, no?
Well, not likely. Most likely it's for macular degeneration.
Where do they put that? Where?
Okay. Where does the injection go?
Yes.
All right. Good. Let me get to the something here to show you. That's just references there. Of course, everybody. Let's go back because I want to show you what you're talking about. All right. So just take the globe right there. The retina stretches all the way around to about here, and there's a little space right here where there is no retina. There's about a if you go 3 millimeters posterior to the limbus is where the cornea meets the sclera, and you measure back about 3 to 3.5 millimeters, there's an area where there's no blood vessels, and you can put an injection in there and not likely to go through the retina and cause a retinal detachment. But one of the potential complications of doing these injections, they're very small in volume. In terms, they're called anti-VEGF injections, which is just Avastin is one of the original names of it. It basically decreases the production of abnormal blood vessels. What happens in wet macular degeneration is abnormal blood vessels start to grow through little defects in Brooks membrane. That's the limiting membrane to the retina. And so these little choroidal capillaries can go through these defects, and they can hemorrhage, especially into the macula over here. So this medicine reverses that process and quiets it down. It doesn't always work. Most of the time it does. But the sooner you catch that, the better off you are.
So do they numb your eye? Do they numb you before they?
Yes.
Okay.
Yes, ma'am.
Okay.
I don't know if everybody heard the question. I'll try to repeat the questions here for you, but the question had to do with injections in the eye that people commonly get for macular degeneration. And the question is, do they numb the eye? Yes, they do. They should, and if they don't, they'll hear about it. But the numbing is pretty straightforward. It doesn't involve an injection. Sometimes for cataract surgery, we do injections in the orbit to give a good local block, but nowadays most people do topical anesthesia that doesn't even require any injections. But you can take 4% xylocaine, you can take other drops that you put in to numb up the conjunctiva, and then you'll put a little pledget of that over that area of the eye for a few minutes. And then by the time you get to that, if you have a patient that's not hysterical, that's not too anxious, they shouldn't feel anything. Maybe a little bit when the injection goes in, but generally it's painless.
And how often do they have to go through that procedure?
How often do they have to go through the procedure? Well, it depends. Generally it's once a month to every 3 months, depending on the response. Some people respond very well and can get by longer, maybe even 6 months, but that's the exception.
And is there any way we can do something so it doesn't happen to us? Because all the people I know that have it are all brown-eyed and I'm blue-eyed.
Well, I don't know of any predilection, brown eyes versus blue eyes, but it's mainly age and genetics. Okay. And some lifestyle things, whether it's you're a smoker, you've got high blood pressure, diabetes, you see vascular issues more often in those contexts. But fundamentally, if you have a genetic family history of macular degeneration, unfortunately, your risk is going to be higher. It doesn't mean you'll get it for sure, but it's certainly higher. Yes, sir?
In any of your research, have you come across, I'm trying to remember exactly what he said, but I believe it was Darwin said that the biggest challenge in his mind to his theory of evolution is the eye.
Exactly. Yeah, I didn't bring it with me, but I did run across that. And it is in the literature for sure. And he tried to explain some exceptions to it, but I don't buy it. But, yes, sir?
You've talked a little bit about anesthesia. I was kind of fascinated. I've been through both cataract surgery and a trabeculectomy for glaucoma, and awake through both of them. And I just was really curious about the kind of anesthesia so that you can be awake while they're doing this. And you can't see much of anything, but you can see movement.
Sure. Well, did you have an IV or did you not have an IV?
I honestly don't remember.
Okay, it's all right. It can be done either way. Typically, the topical anesthesia is the route we try to go, but there are some people that have thin, they're squeezers with their eyes. You can't even get close to them, and you just have to put an injection of xylocaine, not in the eye, but you go below the eye and try to get that xylocaine to circulate behind the eye. And sometimes you even use Marcaine, which is a longer acting anesthetic, to put everything to sleep, and then some IV sedation. But if you can get somebody relaxed, maybe give them 5 milligrams of Valium, play some nice music, put them in a chair that vibrates, and get everything nice and relaxed. Then you get them into the operating room, and you just use some topical drops to numb things up. Once you get through and make your incision through the limbus, which is the junction of the cornea and the sclera, once you get through that, you're not likely to have much discomfort at all, unless for some reason the pressure in the eye would go up quite a bit, maybe some discomfort there.
I think he indicated that I would be out for just a moment or two while he did something, and I'm guessing that would have been the anesthesia in the vein. But then while he was doing that, he would be doing something to the eye to deaden and whatever, because seems like he said he was moving the eye in a different position in order to do the trabeculectomy.
Yeah. Yes, you have to pretty much. I don't know, people don't know what we're talking about here. I guess you and I do a little bit, but trabeculectomy is a filtration procedure for glaucoma where you create a little canal from the anterior. Let's see. The anterior chamber is this space between the cornea and the iris. And then we talked about the outflow tract. Well, what happened? I didn't want to go back anymore. Don't know. There we go. So what you're trying to do when you do a trabeculectomy, and I don't know if anybody wants to hear this or not, but if we've got time, I'll go ahead and do it. But you're creating a larger canal, and you're directing that flap. You make a flap in here, and then you lift the flap up, and then you go through into the anterior chamber, and you create a canal or a fistula that goes up under that flap. You tie down the flap, and hopefully the fluid, the aqueous fluid, will percolate through that, and then be reabsorbed by the conjunctiva. And so that procedure is changed in terms of its success rate, but if you have moderate to severe glaucoma and nothing else has worked in terms of topical drops, then that's certainly one alternative that can be used. Okay, so let's go to the pathology slide. Oh, my daughter Amy. Yes, ma'am.
We were listening to a podcast, and they were saying that they're seeing an increase in young children from watching screens or
Yeah, does everybody hear the question? It has to do with children having problems with the meibomian glands, which is, let me go back to that. Oh, it's right there. The meibomian glands are these glands here on the lower and upper lid that secrete oil to protect the surface of the eye. So why would this be more of an issue than maybe 40 or 50 years ago? It's speculation on my part, but I suspect it's diet. Too much sugar, too much junk food. The best thing you can do if you have meibomian gland dysfunction is to take omega-3 fatty acids, plenty of hydration, eat healthy, cut back on your sugar intake. Of course, that's good for anything in terms of general health. It's not necessarily specific to that. Did they speculate on anything else causing that?
They were saying screens, like, because the kids are not actually blinking.
Okay. So, well, and this is for adults too, and I see this pretty frequently in the office. People will come in and they'll complain of their eyes burning and stinging, or blurred vision, and they can blink and then it clears up temporarily. And basically, if you're on a computer all day long, you're going to be tending to not blink as much. So we talked about this tear film, and that's really if you're looking at the cornea is a refractive surface. It provides us with 70% of our refractive abilities, and the other 30% comes from the lens inside the eye. And so if the tear film, it's kind of like if you think about the window on your car and you got rain coming down and the windshield wipers aren't doing their job, what do you see? Well, the water beads up, your visibility goes down, but in between the beating up of the water, there's dryness that occurs in those epithelial cells. And then if they slough off, then you got a nerve ending right under it that causes the stinging and burning. So it degrades your visual acuity, and yeah, I assume that computer use and games and things that they're doing certainly is a factor. It may not all be from diet, but it's certainly more of an environmental sort of thing that's happening. So I see the. Go ahead. Yes.
Yeah, I was wondering about the interplay between the brain and the eye. I know 90% of the brain's activity is related to the physical body to its gravitational field. And in a situation of, let's say, a motor vehicle crash, you have a breakdown of that communication. And in my situation I've referred more people to ophthalmologists, probably, I'm thinking maybe more than any other doctor, simply to get prism glasses. What is the mechanism that enhances the communication between the brain and body in the presence of a motor vehicle crash or after? And why do the prism glasses take that much pressure off the brain so that it can dedicate its energies now to thinking, healing, and metabolism instead of relating the physical body to its gravitational field?
Okay. Well, there's a lot in that question and a lot of causes and etiologies to explain your question, which has to do with the connections between the eye and the brain and the coordination of everything. But we do have slides that can help you grab hold of this a little bit. Let me go back to, let's see. Okay. I wished I had a slide that showed what happens to the optic nerve, which is in the center, when it goes out of the back of the eye. But basically, both optic nerves decussate right behind both orbits, meaning they come together, and the structure is called the chiasm, where all those nerve fibers come together. And then there's optic radiations that go farther back, and it all ends up in the back of the brain in the occipital cortex. So the eye itself is just gathering information. It gathers that information out there and then analyzes it, sends it, well, not necessarily analyze it, but electrically sends it from the retina through the optic nerve to the occipital cortex, and that's actually where you perceive vision. Your picture is kind of developed. The retina is kind of like the film of the eye, but then that information is sent to the back of the brain. If you had an auto accident, remember there's a lot of nerves that are going to all these extraocular muscles. So it's not unusual, even just in a closed head injury with no actual trauma necessarily, but just concussive force if it's enough. This fourth cranial nerve right here is a very long nerve coming from the brainstem through the orbit and into the eye and innervates the lateral rectus muscle. So just a concussive force could at least temporarily cause the sixth cranial nerve, I said fourth, I meant the sixth cranial nerve not to work like it should. So if your lateral rectus muscle isn't working and that muscle tends to pull the eye, if it's the left eye, then it's a horizontal muscle and it can abduct the eye or turn it out. So if it's not working, then what does that eye do? It turns in. If it turns in and you have normal retinal correspondence, I'm sorry for the terms, but I don't know how else to describe it, then you're going to have double vision. So, and since it's acquired, if it goes away, great. There's a common thing I see fairly commonly, and that's ischemic mononeuropathy, which is typically in diabetics, and they have a small vascular stroke that affects some of the blood vessels that go to, say, either the fourth cranial nerve goes to the superior oblique, either the third or the sixth cranial nerve. And so if that happens, then they're going to see double vision. Usually, if you control their blood sugars and you control their blood pressure, then the small vessels will recanalize and reestablish flow, and that double vision will go away. So typically in those, because I've seen it go away in 6 weeks, 8 weeks, 2-3 months. So if you fit a prism to bend the light to counteract that disparity of alignment, that's what that's for, then typically we wouldn't do it for something that we thought was going to go away because it's expensive. And we just have somebody close one eye, put a patch on or whatever to eliminate, because they're not going to have double vision. The only time they have double vision, it's a binocular phenomenon. So, but in cases that are permanent, that's a different story. Then you would fit them with prism. The problem is if they have a big deviation, the prism gets so thick it's not practical. So you can't fix all of them. Now, you can do, in some cases, strabismus surgery. Typically, you hear strabismus surgery in children that are born with cross eyes, and you do 2 muscles in one eye or 1 muscle in each eye to fix it. I don't know how much detail you guys want. You get me wound up here, and I guess I enjoy this so much, especially explaining to patients. I'll try to get to it. Because most of the time I find when patients are unhappy because they weren't communicated with by their other doctor, and they just felt like it wasn't important to them. And so I was trying to find, I guess I took it out of here, but at any rate, I was going to show you the muscles a little bit. Well, this one's not very good, but if you were cross-eyed, say congenital esotropia, cross-eyed, then one of the common ways to do that would be to do a medial rectus recession, which is the muscle on the other side of the eye, and you go through the conjunctiva, you disinsert the muscle, then you move it back a prescribed amount of usually 3, 4, 5 millimeters or so, and you do it on both sides, depending on how much your preoperative measurements of esotropia are, and then you suture it back down. And most of the time, 60–80% of the time, you hit it on the money, but sometimes you don't. You have to do a second surgery. Okay, let's show some slides real quick, because I think this might mean some more. These are pathological slides, some of which are familiar to you, some of which is not going to be familiar. Okay, so everybody knows what that is. That's a dilated pupil with an almost mature cataract. So you can see if the light's trying to go through that lens, it's not going to get to the retina or the macula, and that's probably a 2200 to 2400 cataract. You don't want to wait until the cataract gets that bad to do it, just because it increases the risk of having a complication. When you're under the microscope doing cataract surgery, you want more light to go through that, bounce off the retina, because that gives the surgeon more depth perception or stereopsis. It's easier to see the layers that you need to see, so that you hopefully don't penetrate through the posterior capsule and lose vitreous. If anybody has any questions as we go through it, just raise your hand. And so this is a picture of dry macular degeneration, which as we get older is unfortunately more common diagnosis. These little yellowish areas you see there are just degenerations and atrophy of the retinal pigment epithelium, which is one of the basement layers between the choroid and the retina. And that, I have seen some people have an eye that looks like that but still could see very well. And I've seen others with less macular degeneration that couldn't. So what you see isn't always what you get in terms of evaluating that. But that's dry macular degeneration, and we'll contrast that with wet AMD or macular degeneration. This is more recent hemorrhage. That's older hemorrhage. You see the coloration difference, so it's been there longer. But that's a really severe case that apparently hasn't been treated, and the vision's going to be 2400 or worse, count fingers vision. So you want to catch that early. That's probably 6 months or 8 months after the fact, with no treatment at all. So if you can catch it early, then your prognosis is better through anti-VEGF injections that we talked about earlier. And this is something that's not that uncommon. This is called a branch retinal vein occlusion. And you can see that there's some hemorrhage that arcs up underneath. That's the superior arcade of Issels up there. So that's a superior temporal branch retinal vein occlusion. The clinical setting for that is almost, not always, but it's age, it's diabetes out of control, and hypertension out of control. Almost always when I see that, one of those or multiple ones of those issues are a problem. And Jeff and Amy, you guys need to get to a soccer game, don't you? No? Are you good? Oh, okay. All right. Okay. So that's exudate. That's exudation of plasma and lipids. And then, unfortunately, it's going into the macular area, so that person's going to have a loss of vision because the macula is involved. So what's the treatment for that? Well, if their blood pressure is high, Mike, thanks. Appreciate you.
I'll talk to you later about natural water.
Okay.
Thank you.
But if that doesn't clear up by lowering the blood pressure, then in this particular case, because the macula is involved, then you need an anti-VEGF injection, and that will help with regression of that. But in case you're curious, right here where that artery is over the top of that vein, you can see some constriction and nicking and pressure on it. And so when the venous return comes back and it gets constricted, then you get hemorrhage because the pressure goes up, and that's what's causing that problem, which is, again, an aging process, poor health, etc.
So I have another
Yes, ma'am.
question on that last picture.
Uh-huh.
So I had a friend who had diabetes.
Mhm.
Her husband wasn't able to go with her to have her treatment, and they put the shot under right above that bone to hold the eyeball straight. So I went in the room with them when they're zapping her, laser stuff. And so I'm sitting there and it's pitch dark. And I'm listening to zip, 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 zip. After about 5 minutes, he's still zipping her. And I think, I'm gonna start counting how many times he's zipping that one eye.
Yeah.
600 times, and I don't even know, what was before that. So is it like when he's doing that, is he staying in one spot? And
Let me do this. I brought some illustrations with me that are not here. I can answer that question with that. When I get through, if you want to come up here, I'll show that to you to help you understand that. I thought there might be a question like that. All right. Now, I hope that photo projects better out there. But the one thing that stands out is this. There's a hemorrhage right there, and that's called a splinter hemorrhage. We not too often see that in glaucoma. And that indicates ischemia and lack of blood flow in that area. So usually what happens, if you see that, usually 3 months, 6 months later, there's a new defect on the visual field because glaucoma affects the field of vision. And then this is just for fun a little bit, but I don't expect anybody to kind of know what's going on, but this right here is a coloboma. This is a congenital problem. That's the optic nerve right there. But that whole area right there is absent, and it is an embryological problem that occurred in utero. And there would be a pretty big visual field defect associated with that. And then the last one is called papilledema. So papilledema is a swollen disc, and that disc is swollen up because there's increased intracranial pressure. And one of the more common things is idiopathic, I'm blanking. Pseudocerebri is the old terminology for it, intracranial hypertension. And so if the doctor sees that, then basically we're referring to a neurologist or a neurosurgeon to do a spinal tap to figure out why the pressure is elevated and to solve the problem. So if somebody has headaches, there's not much, believe it or not, usually there's not a big loss of vision with this. You would think there would be, but unless it involves the macula. So, anyway. Okay, any other quick questions? I think David's about ready to kick me off the front up here.
If you have
Okay.
questions.
Anything else from anybody?
So you've done thousands of surgeries. Has there ever been one where you walked away and was like, just saw the majesty of God in that surgery?
I'll answer that kind of indirectly. And the question had to do, did I ever do a surgery in which I saw the majesty of God? Well, I think when you look at the nuts and bolts of things, and I would pray before every case, or before I did several cases, and if we got into some problems where it was difficult, then, I just, Lord, calm me down, help me. And he was very consistent in that. It doesn't mean I never had a complication, but I was amazed at the peace and the reassurance that the Holy Spirit provides, because it's a pretty stressful environment. But I'm still living, and I still enjoy. I've stopped doing surgery a few years ago, so. But I basically do office ophthalmology a couple days a week because I still enjoy it. So I'm not ready to retire yet. All right. Yes, anything else? All righty.